Good morning and welcome to another Esoc, this time in Helsinki. I arrived safely on Sunday with the Finnish Eurovision delegate from Basel. But now we are in Helsinki and we're going to have some great days here. So this morning I'm joined with Robin Lemmens. I'm joined with Mira Kotan, who is the chair of the conference, Tina Sairanen, it's a difficult name, the Finnish names, and Daniel Strabian from the local organizing committee. And we're going to talk to you a bit about today, about the highlights, what we are to expect, and with the beautiful weather that's been in Helsinki, I also want to hear what should we do when we sneak off from the conference. So, Robin.
Well, I think we could ask Daniel first, because he's been very looking forward, I think, for this conference in Helsinki, because it was planned for 21, and everyone probably knows why it was postponed. So now finally in 2025 we have the 11th Esoc in Helsinki. So Daniel, tell us a little bit about Helsinki.
Well, you know, it still seems a little bit surrealistic for me that we are here actually eventually, and I'm very grateful for that the site was selected. And I would say that, you know, like anybody who is coming to Helsinki can enjoy. This is maybe like the architecture-wise, of course, it's different that you can expect in Europe. It's mostly a very beautiful modern architecture that you can enjoy, but a lot of stuff like you can do like open space in the nature and so on, archipelago. And I think this is something that anybody can choose from. But I hope that from the heavy program of the conference, everybody will find something for themselves, at least from one of the parallel sessions. So I think it will be a very successful conference.
So from the heavy program, we have to go to the chair of this heavy program, who's going to share some insights about this heavy program in the conference.
So I'm really excited to be here. It's a beautiful city, so you really have a nice place you can live in. It's beautiful weather, and it was really thrilling to be here. And we do have a very nice program. We do have more than 4,000 registries coming from all over the world, and we'll see later on where they're coming from. And we do have more than 2,000 abstracts. And we will have a lot of interesting scientific sessions, scientific communication, workshops. I think it's going to be a great gathering, and we have time to talk to all our friends from the different countries around here and have a great interaction, I'm sure. It's going to be a really, really nice program. Hopefully not too heavy.
Anything you're looking forward to, Daniel, especially today?
Well, we are actually starting a session co-chair with Mira. There will be 9 trials presented. Some of them are actually secondary analysis of trials presented this year, distal and MEVO escape. And then some rehabilitation trials. I'm very eager to hear those. And then there will be one trial about tirofiban plus IVT. And then a bridge tenecteplase trial. So those are maybe the highlights.
I think, and also the Optimist trial, yes, which will tell us, do we need to monitor our TPA patients or thrombolysis patients as closely as we do now? So, which is a very service delivery trial, which I think is, I'm very excited about those results as well. So, but I'm glad we have the secondary analysis of the MEVO trials. I think that those trials has left us a bit uncertain. What should we do? Who should we treat? So getting a bit more insight in the subgroup, the patients, what was going on in these trials will be very interesting and hopefully bring us a bit forward.
Yeah, where to get from there, you know, where we have the negative trials. We have had that in the past, or neutral trials. But then we learn a lot about them to get potentially to the next ones. So yeah, I'm looking forward to that as well. And also the bridge TNK, I think it's going to be really exciting as well, I guess. And yeah, really nice program. And I think what really is also nice that we do have like the whole, you know, patient care pathway. So we have, you know, pre-hospital trials, we do have trials, acute treatment, we do have secondary prevention, rehab, really the whole bunch which we are interested in. For everybody, there is really something very interesting to be listening to.
Yeah, that's true. Yeah. That's true probably for every plenary session, right?
Yeah,
Because we're talking about today, but I think every day as a plenary session where for everyone with a particular interest there will be something presented, which is very nicely organized, I think. Yeah.
Definitely. And on the last day, I think we also have some pre-hospital trials, which of course is also an important part of the pathway. So
Exactly.
yeah.
So we have our local committee, 2 people from the local committee. So it's always special if such a big conference is coming to your city. So is there anything that in particular was organized by your local committee which is associated with this conference?
Yeah, there are. They are of ours. Not to be disturbing the heavy program which we just discussed, which will be the main topic. So today one can join the beach volley, which is inside, just to secure that the weather doesn't disturb the playing. And if you're still here on Friday, there will be a possibility of move like the Finns. The physiotherapists of our center have organized that one. Cool. So it will be traditional, some more untraditional things to do outside, as we do. Most of our sports are outside. So, and if you still live in Helsinki, still be in Helsinki after the conference, so there will be a nice possibility to join the women's fun run, a 10K run or walk, whatever you prefer, and even men can participate. Also, it has a tradition. It has a long tradition of being first for females, and now it's like equal.
I like this country.
So stay fit and healthy is the main theme in the parallel events.
Yes. So we talked about, Merit mentioned this, I think, networking. So do you still remember like your first conferences and the networking part? Well, so there are probably people now watching and coming to their first conference, maybe the second. So what do you tell these people? So what should they be doing? It's a large conference area. There are a lot of things going on at the same time. How to deal with that? What would be your advice?
Yeah, I think, first of all, it might be also even a bit overwhelming because there are lots of talks and people and lots of posters but it is really. I remember the first conference I ever was a big conference in the US, and I was there a bit afraid, but then it was so nice just to start to talk around, just next poster, and you could go from there, and then you learn other people's opinion, and then next time you're much more convenient about talking to other people, and then you go on and you find friends such as I found Else. I remember her on the stage in London at the time. Yeah, so I was really very impressed, and other cool people. So I think it is really worthwhile over the years, and it is very inspiring to hear, as I said, like the whole spectrum of stroke, because you're maybe sometimes just in your bubble, and to have like these cross links, and to have also the views from people you might not interact directly in your research group, even if you have larger consortia from other countries, you have some inspiration on the side when you walk down the corridor and you have a talk and over a poster from a total different area, and you might get really inspired from that as well. So I think it's really nice to be also here in person. This is also a big issue.
Yeah.
I think that's when you meet people as well, organize things in the evenings. Say, should we meet up later? And also get the social part of it and get to know people on a bit of a different level, not just by the poster, but also have dinner, go out for drinks in the evening, and in a way you will create your kind of group of people that you meet at every conference 15 years later, which is a cross between colleagues and friends, which is quite unique in the scientific community. So and very cool, and you start your collaborations through that. And I think all of us probably have some of the people we collaborate with started off as someone we spoke to next to a poster 15 years ago. So I think it was the most important advice I got from my mentor, Eivind Berge, who told me, my first conference in Nice 2008, he told me, meet 3 new people, learn 2 things. And I think it's a good advice. Meet 3 new people. It's yeah.
And of course for social events, so we took it last year to the next level by organizing the first ever Esoc party, and of course we didn't know, like, are we going to do it again? And then we've been told, yes, you must do it. So now again we are going to have another Esoc party tomorrow, just after the faculty dinner. So we have more than 1,000 people who have already registered, and more can still do it online.
And what we have here in Helsinki, or what we have here up north, rather than in Basel, is that it doesn't get
Yes.
dark.
Yeah,
We have the very long evening, which is it does something to you. It gives you extra energy. It also makes you wake up very early in the morning, but it makes you a bit time zone confused. But it's also amazing, and I think it's the same here in Helsinki as in Oslo, where I come from, where people hibernate during the winter and you don't see people. And then as we come to this time of year, you start speaking to your neighbors and you say hello to people on the bus.
Still there, still there.
Sounds familiar.
It's we are a bit different here up north because we hibernate and then it all opens up and we're at the prime point of the evening light.
Yeah. So it also highlights again, I think, that we should do this like we're doing it. Currently, I think there's always been discussion about people traveling from all over the world, right, Daniel? So what are your thoughts about this?
Well, if you are referring to the traveling by plane, then of course, I mean, this is something that we have to consider, right, for the selection of the sites for the future, definitely. So one part is just the green aspect. And another one, what we are facing maybe a little bit more frequent in the last years, that is always some trouble with flying, right? There's some strike going on, maybe some problem with the companies and so on. And of course, it's affecting some people. Maybe in partially it actually happened this Monday and last Friday. So this is very unpleasant part of the conference. So maybe for the future, it's actually wiser to have it, like say, in Europe where anybody can reach it by train, bus, or actually some of our colleagues by bike.
I don't know why pointing towards me.
So,
Didn't you bike to Basel last year?
No, I traveled by train, which was quite a challenge as well. No, but I think it's good that we talk about these things first, and then we have to be considerate about these things. But on the other hand, I think, as was mentioned before, this is a moment where you are able, especially if you're a young researcher, where you're able to reach out and meet people. Of course, also if you're more further in your career, it's good to meet people again. But especially if you really want to talk to someone for the first time, I think this is really critical. I always see this if you go around these posters and you see that probably someone is presenting their first poster, they're probably pretty anxious. Someone is asking them questions. But these are the very important first steps that you have to take, because in the end you will be giving presentations and you have to become familiar with this, and also that you will be receiving questions and to think about the answers that you will give. That's how you will grow in your research area. So I think it's very important to have that in person.
And you can even, I have a little anecdote with the poster, you can even meet your future husband. It happened to me. So you don't expect that, but it did. It's a true story.
So Mira as a CPG chair and wedding planner. So is there anything in particular you're looking forward to as it relates to the conference? Because we talked about the local activities that you have. So what are you looking forward to for this?
Yeah, actually, as a continuation of what you just spoke about, the big ones, the big trials, which we're all expecting, what results or what optimization will come out of them. Actually, my picks will be on the rehabilitation side, because I think that our acute treatment has changed the landscape of the rehabilitation. We see it in our rehabilitation ward. We need more speech therapists, more neuropsychologists than we did before. So the milder the symptomatology of the hemiparesis gets, the more important are the language and
neuropsychological
skills. So I will be looking for those.
Yes, so it's important that we're looking forward to doing this rehab trial. I think it's an important item to mention, because we've been focused a lot on acute treatment of ischemic stroke with all the trials we've been doing for many years, and we've made so much progress. But I think in this particular area, there's probably a lot of progress still to be made. And I think it's good to see that we have several trials here now as well on this particular topic, and let's hope that that will be also for the future.
There's actually going to be today, like one of the trials is not related maybe exactly to what Tina was referring to, but it's about like pre-discharge home visit compared to the regular one. So let's see about results.
And that's, again, service delivery,
Yeah.
and how are we going to deliver services to the patients in the best way? We keep going at what we have been doing for a long time without really changing, even though the landscape is changing. So I think service delivery trials, it's really important, the rehab trials. But it also get another aspect of it, that is that a lot of our patients have milder symptoms when they come into the hospital as well. In Norway, there's been a shift from the more larger strokes to the more moderate or minor strokes. And are we measuring the deficits in the right way when we are doing the trials? That is also another important question, because the MRS it measures it well, but it is also quite crude and perhaps does not capture the deficits that you see on the rehab board. So, yeah.
Absolutely. I think, yeah, the shift in symptoms with the acute treatments, which improve, obviously, outcomes, what we want, but has a shift in symptoms also for rehab, as you said. And I think that's a very interesting area as well. And with all new technologies also, I think that's also very important with, robot assistance therapies and so on. I think this is really also a huge topic, and with maybe even a bit more in the future, computer-brain interfaces. So I think there is lots of things we can still look at also in the rehab world. Yeah.
So always when such a conference visits a particular city in Europe, sometimes this also sheds some light on stroke awareness in that particular city or maybe hospital. Have you noticed anything in particular related to that, or are there potentially activities maybe in the hospital? I'm not aware even, but is there anything that you think that will come out for Helsinki about Esoc visiting this particular city?
Yeah, I don't know. Do you want to mention anything about this?
Yeah, I think we took it all up. Yeah, we have lots of activities. It's like the brain health is an issue which we take seriously. So we actually have lots of things going on. The Helsinki city's info screens have posts on this congress, but not only on the congress, but on get your blood pressure measured. So for the lay public. And for the lay public, we will be measuring their blood pressures in the Women's Fun Run on Saturday. And for permanent use, we have upgraded our websites, which are provided by the healthcare professionals for the lay people, with brain health pages, which were just launched. And some colleagues of ours have been brave enough to be posting videos on social media. So one video per day during this conference will be coming up on the brain health issues.
Wow, that's
we do have, that's a hard thing for us.
Yeah, it's really impressive.
And maybe, I don't know if you notice, the screens that Tina was mentioning, so we have several of them in the Helsinki. I think that one was supposed to be at the airport. And basically, we are just telling the people the most important risk factors of stroke and what they should do about it. And of course, like Tina mentioned, they can find some more information on the web pages. And well, if the idea is that if at least they follow the suggestion to take care of one or two risk factors, they are doing already something that they did not do before.
Yeah, for sure. So, and we're visiting Helsinki now 4 years later, right? So, what are your thoughts if you look back and now plan it again, Daniel, about Esoc coming to Helsinki? You must be pretty reassured that everyone has now made it, although Monday was a little bit stressful for you, as I know. So what are your sort of final thoughts before we start opening the conference?
Well, Robin, I can just say that, it's really, it's a team of people. So first of all, our local organizing committee, then what Mira and the whole CPG was doing, and on top of that, the professional people from Congreg. So, you cannot do it together, right? So yes, you have the site selected, but then you need the people who are going to do it. So basically, I just want to thank everybody I just mentioned. And I don't know if I will change anything. I think it just went as it was supposed to go, and here we are again in 2025. So
that's for sure. And so then we're going to ask Mira, because you're the chair. So what are your final remarks towards the public who is now ready to get started?
Yeah, so get ready. It's a really rich program. We have lots to learn and lots to hear, and get in contact. So we heard 3 to 2 people, new friends, very important, and don't miss the party.
That's for sure. That's for sure. So I hope that you will all enjoy the conference, which is starting in 10 minutes. And so we're looking forward to seeing you around, and I hope all of you have a great conference.
you. All right, so welcome this morning at the first TV studio session here in Helsinki at the Esoc conference. And I'm happy that we can talk about a very important topic, I think, and still a controversial topic in endovascular treatment of acute ischemic stroke. And that is the use of a balloon guide. I know that there are physicians that really like to use it always. There are physicians that use it once in a while, and there are physicians that say you should never use it. So let's have a discussion about this, why we think, the three of us here, and let me introduce you then, Tobias Buck-Berends and Maria Berdenmuck, both from the Technical University in Munich, both neurointerventionalists, and they will talk about the use of a balloon guide, maybe convince you to use a balloon guide, but at least show the advantages of using a balloon guide, and especially the newer generation balloon guides that we are going to talk about. We start with a kind of introduction about what is a balloon guide, how do we use it, and that will be done by Tobias, and then we will discuss some cases with Maria. She has prepared some cases, and we'll see how you will think finally what is the benefit of using a balloon guide. So Tobias, I leave it to you to start the introduction, and in the meantime we will see how we get to the cases and what the evidence is.
So, thank you, Wim. Thank you very much. And exactly, I will just start with a very short explanation of the basic principle of the using a balloon guide. This is a short movie where you can see that when you have a clot in the distal vessel, and then you use a stent retriever, you have a balloon guider in the ICA, and then you inflate the balloon, you get the flow arrested, and if you then withdraw the clot inside the stent retriever, this is the point where you can achieve a flow reversal through the balloon guider. And if some fragments occur, this is exactly the moment when you open up the balloon guider or you do not have one, then these fragments will go upwards and produce exactly something like this, what is shown here in this case, where you have an M1 occlusion successfully reperfused, and you see in the control run that there's a new occlusion which has not been there before, which we call an ENT, so an embolization to new territories. And this is exactly what we really want to prevent with these kind of devices. And regarding the evidence that you mentioned, we have actually a lot of evidence. This is a review where you can see that nearly in all really important points like TICI, so successful reperfusion, also the MRS variables, so outcome data, they all show a benefit of using a balloon guiding catheter, and this is also true for the different techniques that we can use, like stent retriever alone or a combination technique. And of course, all these studies that we see here are not randomized, but also some of them are registries, so large, also prospective registries. So the evidence is not really high at this point, and
But these are all done with the first generation balloon guides, isn't it?
Exactly.
The ones you show here.
Yes, exactly. All the evidence actually that we have, nearly all the evidence, was achieved for the older generation balloon guiders. And then after these retrospective studies, and we have now 2 randomized trials. One of them are from China, one of them from the UK. And the interesting thing is that these 2 trials show a complete different image. So you see on the left side there are the outcome data from the Chinese study, and on the right side from the UK study. And especially in the MRS variables from 3 to 6, you see the difference is it's completely the opposite what you see in these 2 trials. And also, if you look at the secondary endpoints, like the things that we want to prevent by using the balloon, like the ENTs. In the UK study, it was positive, and not in the Chinese study. The symptomatic hemorrhages were lower in the UK study in ProFate and higher in PROTECT-MT. The same is true for the mortality and also the success rates that we saw.
Yeah, most important thing I think in the first line that what you want to prevent, ENTs, is clearly shown in the British study, where there was a percentage of ENTs of 12% in the control group, so with a conventional guide catheter, and they could reduce it with a balloon guide to less than 1.5%. And you don't see, first in the control group in the Chinese arm, it's only 4%, so that is different. And it didn't change when they used the balloon guide. And for the other outcomes, of course, they are secondary, more or less, to the first outcome. It's a surprise. Do you have an explanation why there's such a difference between the outcomes in those two trials?
Well, actually, I think it's difficult because the study itself, it's published in Lancet, so it's a good designed study if you look at it in the first place. But it's the only study that we have that is completely contradictory to every evidence that we have, not only to the other randomized trial.
The Chinese is also contradictory to the old evidence that we had from
exactly.
The earlier.
And what I think is one of the main points why we can explain these different results is an aspect that we will discuss later. It's the influence of the tip position of the balloon guiding catheter, which was in the guidelines of the PROTECT-MT trial. They just recommended to use the balloon guider in the low cervical position.
So it was recommended even in the trial itself to place it in a proximal position and not distal. And for the
conventional guiding catheters, it was recommended to place it as
distal,
as distally as possible. So this is one of the possible explanations. Another thing is, of course, if you're used to use these kind of devices, then you have a learning curve, like in everything.
Yeah. So do we have an indication that in the Chinese group, the physicians were not used to use a balloon guide, and that they had to do it here in this trial?
It is not published, so we cannot see it from the also not in the supplemental things that we have. But they were experienced interventionalists. That is shown in the data. Yeah. But not how many or how they are used to the balloon guiding catheters.
No. So placing the tip very distal might have been of influence in the outcome, in especially the Chinese study where they didn't place it very distal. And that maybe is because they used all the generations, which are stiffer and not so easily guiding up to the distal position.
Exactly. I think this is one of the major points where the newer generation of guiding catheters really change a lot. And as I said, this is the level of evidence that we have now. So there are recommendations to use these, but it is, as I showed, it's really in discussion.
Yeah, and with the two new studies that are so contradictory in their outcome, we cannot really update the evidence. I mean, there's still not convincing evidence.
Absolutely. And now, if we're talking about the newer generations, then the only evidence that we had was this one for the Walrus. So the newer generations are, at least in Europe, which is available, is the Walrus and the EmboGuard and the Bobby. All these three are completely different to the older generation devices. And So we have this retrospective study from the walrus which showed quite good results, and now we have another study performed evaluating prospectively the Bobby guiding catheter, which is this one, and which is obviously completely different to the older generation devices. And what you can do with these kind of catheters can be shown by an example.
Yeah, so Maria, you had an example of how you can use the newer generation and how it is possible to bring it to a more distal position than with the older, stiffer ones.
So here I have a case. It's an 85-old woman who came with a right-sided carotid T occlusion. She was highly affected with the right hemispheric syndrome. And then you make the first run and see that kind of arterial access. It's very challenging, as you might know. So I want to show you how we made that. We had a short sheath, we had the balloon guide catheter, the Bobby in between, and then we had the diagnostic catheter. We used a SIM to get the wire up. And then, as you can hear in the video, the SIM catheter stucks there. It does not go further. And then what you do, you take the balloon catheter and it follows very smooth. The old ones, the conventional catheters and all the old generation balloon guiding catheters would not do that so smooth. So it's one characteristic of the new generation catheter, and then it follows the catheter, but it does not go further. Then you inflate the balloon and you use the balloon as a sail. It's like a kite that uses the wind to go up. Here you can use a balloon to go up with the bloodstream and generates the stability to get the diagnostic catheter more up. Then you deflate the balloon again and follow the diagnostic catheter.
So in this case, you inflate the balloon to let it go with the flow, or did you also inflate it to have a more strong anchor to bring up the diagnostic catheter?
That I wanted to say, that's the second thing you can do. In this case, it was not necessary to inflate it so much that it stuck in the vessel. This is the second thing we do if this we have success with that. Then we use it as an anchor, that we then have the pressure to get the other devices up.
So here you let it flow.
We'll let it flow like the kite flies in the wind.
Okay, great. Yeah.
So before we go further on this case, let's go back to the evidence we have for the new generation balloon guiding catheter.
Yeah, just very briefly talking about the straight study, which I mentioned before, which is this prospective evaluation of the Bobby. It was a multi-center trial in several centers in Germany and Switzerland, and we enrolled about 170 patients. The primary endpoint was a technical one, was the successful reperfusion, but we had a very close look at a lot of secondary endpoints, looking at the performance characteristics, but also safety, of course, and procedural and outcome data. So the population is quite standard, nothing special. The occlusions that were treated are mainly M1 and M2 occlusions, only a small subset of ICA occlusions. And now coming directly to the primary endpoint. So the successful reperfusion was 95%. Which is exactly the number of the retrospective walrus study, and very high. But these are data that are core lab controlled and prospective, so have another quality, I think. And the first pass effect is also nearly identical, very high with 63%. Outcome data also very good, more than 60%. Independent outcome and quite low mortality rate. So these are the basic evaluations or data from this prospective trial, which is not yet published, but will be soon. And then we had really a closer look also at technical details in this study. And the first thing is that we looked how good is it possible to place these kind of catheters in the distal position, what we talked about before, and this was quite good in 2/3 of the patients, we could place it at least in the mid-segmental part of the ICA.
So in the trial, it was registered how this or the place where you positioned the balloon guide in the prototype, because in the older in the older trials and the evidence that you showed, we had no idea. Usually they place it very proximal because it was not possible. So it's good to see that you recorded the position of the balloon guide in this trial, because I think that's one of the main things, the most important factor for the success.
Yeah, we planned that from the beginning because you have to also have the images where you can see this. So yes, this was one important endpoint for the study, and of course it is dependent on the anatomy, obviously. And yeah, maybe regarding that point, Maria can continue with the case from.
So I show you how to get the catheter up. Let's go back to the carotid tear occlusion from before. So we have brought the balloon guiding catheter in the proximal part of the ICA. And now here you can see the angle. That's a very small angle and very tortuous vessel. And with the conventional navigation techniques, it may not be possible to bring the catheter more up. So I can show you one trick you may know from the aspiration maneuvers. So you bring the stent retriever through the thrombus, expand the stent retriever, and then use the stent retriever as an anchor. You pull on the wire of the stent retriever, and then you can straighten the vessel, as you can see here in the video. And then you can bring up your balloon guiding catheter to the point of the skull base. You see here it walks up very easily when the vessel is straightened, and then reaching that point, it's a correct place to open the balloon for the maneuver. So we did the maneuver with a combination technique, aspiration, stent retriever, and also the proximal flow arrest at this point, at the skull base. It worked very well. But if you have to do second or third maneuvers, then you have brought the balloon guiding catheter at the right place with this maneuver, but you have to care about that. You have to keep an eye on the balloon, because when you pull on your wire, sometimes it goes up. That's not good. If the balloon is inflated, you may cause these dissections. And also, if you pull the stent retriever completely out, sometimes you lose your position, your high position. So you have to care about when making the maneuver.
Yeah, so if you take out the stent retriever through the balloon guide, you keep a hand on the balloon guide to pull it back if it's going up?
Always.
So keep control on the balloon guide.
Always do that. To not do the anchor maneuver again for the next maneuver. So why it is so important to bring the catheter up to the skull base? Julius will tell you.
And what you discussed here, that you really have to have a control over the balloon guide, underlines further that you need a little bit of experience of using it.
But I know that some of our colleague physicians say that with the balloon guide, you have this risk of making dissections, and that's exactly when you let it go up while you push. But I know with conventional guide catheters, we also see dissections. I don't think there's a big difference. It's something that we should look at also in these kind of trials. See we more dissections with balloon guide? I don't think so, but that impression is with many physicians.
Actually, in the two randomized trials, that was one point where they looked at, and even in the negative Chinese trial, it was equal.
It was equal. That's the proof. I think that's an impression that some have, but it's not the case probably.
Okay, so coming back to the data, why we talked always that it's important to go upwards, but do we really have data to underline why we think this is important? And in the straight data, we saw actually a quite significant drop in the reperfusion, at least in the first pass reperfusion rate, between the mid-segmental and the proximal placement. Of course, everything mediated by the anatomy. But this effect is not the first time that it was seen. So also in the ASSIST registry, they published a paper where they saw this already with a quite large effect. And the reason for this effect on outcome and reperfusion is probably that if you place the balloon in the high cervical segment, then the ICA is fixed in the petrous canal. So if you then aspirate, you can really create backflow. If you create or you aspirate from a proximal position, then what you can see in the video, the ICA will just collapse, and you create a lot of force at that position, and then all the debris and fragments will just stay upwards, distally of the balloon guiding catheter, and then if you open up again, then everything goes upwards. And I think this is the main reason.
Yeah, that's very well possible. I've seen a case once where a stent was in place already in the internal carotid artery, a wall stent, and they used a balloon guide, aspirated on it, and even the wall stent collapsed. So there's an enormous force when you aspirate, especially, well, if you do it very proximal, it's quite evident that the vessel will collapse then.
I think you only can prevent it if you create this effect, then you can just use it passively. You just open the valve and then it just runs passively through. But you have to think before reopening the balloon that you really need backflow before you reopen. And sometimes it's not possible. And then
no. So we have a good explanation. We have evidence now from your straight registry that placing it more distal leads to better outcomes. So I think that's a very important message. If you use a balloon guide, place it distally, and that's possible now with the newer generation.
Yeah, I think so. So then I think this is enough and evidence that I don't think we have to talk about that. I think in conclusion, or in a preliminary conclusion, we could say that the data that we have now further support that now having the newer generation devices, the results improved further. And that the tip position really plays an important role. So if somebody is thinking about doing another trial, which I think will become necessary, all these aspects I think should be considered beforehand in the planning phase. But I think these are not the only reasons to use a balloon guiding catheter.
No, you look, of course, at the prevention of distal emboli and then finally the outcome. But technically, and you showed already in that case that it can help you passing difficult anatomy. And I think that's what your last sentence. You can use it in many ways, and we have seen examples of that, how it can be helpful in other situations, and you have more examples I heard with other ways of using the balloon guide or other, well, I wouldn't say indications, but reason that it can be helpful.
So maybe another scenario, we also have evidence for using it in cases of tandem occlusions, where we have to stent the ICA. It's of course emboli protection, but also the studies show that we have a shorter procedure time, we have more success for recanalization, and we have a better outcome when using the balloon guiding catheter for tandem occlusions. Well, what we do always when you do elective stenting, we always use the balloon guiding catheter during the navigation, during the PTA, and during the stent placement, and have backflow on the balloon guiding or aspirate on that to prevent the emboli.
So also in elective cases of carotid stenting nowadays you use a balloon guide?
Always.
Always, yeah.
So here's a case for that. It was a patient with a post-radiogenic stenosis in the ICA. This are the arterial access pictures where you can imagine it's not easy to go there. The external hospital tried it and failed because they did not have the balloon guiding catheter. So the patient came to us, and what we did, we used the balloon guiding first to generate stability. In the middle picture you see we inflated the balloon and then had it as an anchor for stability to get the PTA balloon up there through the tortuous vessels. And then we inflate the PTA balloon, deflate the balloon guiding balloon, and then we can move it up. Yeah, it was a technique that worked to bring the balloon guiding in the common carotid artery direct directly
This is again difficult anatomy, how you can use it to overcome this difficult
to
anatomy.
come there. And then we have it at the right position to open the balloon and have the emboli protection during the stenting procedure.
Yeah.
So let's come to another case. It's a patient we were contacted from the internal department. They wanted to place a central venous catheter in the jugular vein, but they punctured the common carotid artery. And what happened? A big hematoma that expanded into the mediastinum, and we had a pseudoaneurysm, a big aneurysm that also has thrombus in the aneurysmal sac. And then they said, okay, what can you do? And first we thought, okay, placing a stent graft, but that was not possible because of the underlying hematological disease of the patient. He should not become antiplatelets. So we decided, okay, then we try coiling of the aneurysm. And then we decided to use a balloon guiding again to bring it in the common carotid artery to have, again, the ambulatory protection, because when we insert the coils, there's so much ambulous material that we feared to mobilize that and did not want to generate a stroke
So
in this
did
procedure.
you aspirate through the balloon at that time for this occasion, or just passively place the balloon and
We always open the back valve and then leave the allow
so
backflow,
passively,
that all the fragments we possibly mobilize go back.
But
Because of
you
the
do not
pressure valve.
actively aspirate during this coiling
No,
procedure.
it should come to, there's too much blood that comes
yeah,
back.
yeah.
So that was the
takes
result.
time, actually.
It takes time. That was the result of that coiling.
Yeah.
So let's come to the last case. We had a young lady that came with an intracranial MT occlusion due to this dissection of the ACI. You can see here the typical sign. And as you know, it's sometimes not so easy to reach the true lumen when you want to navigate to come up. So I can show you one trick. It's from, thanks to Jan Gralla from Bern for the nice drawings. As you can see here, the dissection membrane hinders the way to go into the true lumen, and then you use a balloon guiding catheter. You inflate the balloon, get backflow, and then the membrane will dislocate, and then you have the right way to find into the true lumen. And what you also can do, you have a second access into the contralateral artery, then you make a series, and then you can visualize your way that you have to navigate and find on the right side here, the right way into the true lumen. That is very helpful in such cases where it's not possible.
It's nice to visualize it like this. It's a very nice maneuver. I've done it once, but it works. So if you can't enter the true lumen, you inflate the balloon, aspirate, and then suddenly there's a lot of space. Then it goes up easily.
It's quick, and you don't have so much complications while navigating into the
for the
dissection.
interventionists who are not familiar with this maneuver, I think it is very helpful in difficult situations of dissection. Yeah.
So after navigating, we brought up the balloon guiding catheter to the right position at the skull base. We made the recanalization of the MT occlusion. It worked very well, but there was a distal occlusion, maybe an embolus. And it was a young lady, so we said, okay, let's go for that too. And as you can imagine, what happened, we perforated the vessel, and then what can you do? The quickest thing you can do is inflate the balloon. You have it on board, you have it at the skull base, you can inflate it and reduce the inflow pressure. And that, with that you gain time for all the other things you have to do when you have a perforation for temporary or permanent coiling procedure, for example. So that's a good safety.
No, I think this is a very important aspect of the balloon guide as well, and we discussed that in our team as well. As soon as you have a perforation, the fastest thing you can do is just inflate the balloon, and you lower the pressure already, and then you have more time to think how you solve this problem of a perforation. If you don't have a balloon guide, you want to act fast, use a temporary coil or use a neuro balloon, but that takes time. Or press. That's true, you can press the carotid, that's another thing. But this is so easy, it goes very fast. So yes, it's a very nice example how you can use a balloon guide to help you in these complication situations. Yeah, I think we have seen now, of course, the aim of a balloon guide to prevent distal emboli. We have yeah, we have evidence. We had already evidence from the past with the older generation balloon guides, but now you showed clearly that if you place it more distally, you have much better effect of the balloon guide, and that is possible with the newer generation. So I think even for those physicians that thought over the past years, well, what is the additional value of a balloon guide? I can do just as well with a normal guide catheter. That was probably because it was more difficult to get a balloon guide up, so they struggled to get it up. Now with the newer generation, I think they will see that if they use that one, it is just as easy as a normal guide catheter, but you have the advantage of a balloon guide, not only to prevent distal emboli, but also in other situations, like when you have a perforation, like when you have difficult anatomy. I think there are many, many ways that you will find your benefit of using a balloon guide. And the last thing, preparing a balloon guide, it takes you a few seconds, and you can do that while someone else is doing the puncture or whatever, or you do the puncture and your technician prepares the balloon. I don't think that that's a reason not to use it, that you don't delay the procedure. No, thank you very much. They were very nice cases, and I think the evidence, you said we need a new randomized trial. Are you thinking about it, to do it, or?
Yes, I am, but, or we are, but, well, it's difficult because we need a lot of money for that.
Yeah.
So
Okay.
but
We discussed
well,
that afterwards.
yes,
But I think that would be nice. Because,
Yes.
again, with those two trials, we do not change the evidence that is currently in the guidelines. So I think we need stronger evidence, and with the newer generation, I think we can get the evidence that it works better. Okay, I think we're at the end of this nice session. Thank you very much again for showing the cases, for showing the results of the straight and the other studies. And I hope that the audience has learned something from it. I don't know if we have convinced them to use it, but maybe we helped them a bit in seeing what the benefits are of using a balloon guide. Thank you very much. Thank you.
thank you.
Welcome to this edition of ESO TV Midday Highlights. I'm Peter Kelly, ESO past president. I'm here with my co-moderator, Alameen Algra, and our esteemed guests, Diana Aguiar de Souza, welcome, and Valeria Queso, very welcome today. So we've just come from an absolutely wonderful first plenary session of Esoc, a fantastic mix of different studies, different trials, different themes presented. And we're very fortunate to have one of our presenters with us this afternoon. Diana presented her work on CVT and provided us with some really wonderful new information. So Diana, could you tell us a little bit more about your study?
Thank you very much for asking us. Yes, so this trial is a cluster randomized trial on the duration of anticoagulation after an episode of cerebral venous thrombosis, in which there is no indication, has decided by the treating physicians, to do permanent anticoagulation. This trial, this cluster randomized trial, was complemented by an observational study, prospective, with a similar design, that patients were also allocated either to a short-term policy, which was defined as 3 to 6 months of anticoagulation after the episode of CVT, or long-term duration, which was defined as 12 months duration of anticoagulation after CVT. So overall, the study included more than 1,200 patients, with 460 in the cluster randomized trial and the remaining on the observational study. And yes, we could have some interesting results as well for this first 12 months of follow-up.
Okay, so what were the main results?
Yes, so the study has a 24 months follow-up. We are here discussing the first 12 months, which is the period where the two policies differ, and we can directly compare the groups of patients that were on the short term and stopped anticoagulation, and on the long term and were all the time under anticoagulation on an intention to treat basis analysis. And indeed, we couldn't find difference on the recurrence of venous thrombotic events across the two groups, both in the cluster randomized data and also on the observational study. Actually, all results are very consistent. Also, we couldn't find differences in terms of the major bleeding and also on the composite outcome of major bleeding and venous thrombotic events. Interestingly, we found numerically higher rates of death and vascular death in patients on the long-term policy, and this was also consistent both in the cluster randomized trial and in the observational study, although the adjusted analysis for possible confounders was not statistically significant, the difference between the groups. So overall, we believe this is important data that should be used and considered when doing the specific and individualized decision on duration of anticoagulation with patients. Of course, this should be tailored to the specific situation, but this is an indication that at least we couldn't see an early benefit of an extended duration of anticoagulation, and there's possibly a sign of increased numerically higher rates, at least, of death in these patients that are on the long term.
Yeah, fantastic data. One of the things that really impressed me about your study was the global reach of the countries and the hospitals that you had participating in it. So how many countries did you have participating? And related to that, what was the breakdown of anticoagulation use in, say, in the CRT, in the cluster randomized trial?
Yes, so we are very happy that indeed CVT is a global disease, and indeed the participation is also very representative. We have centers in India and Mexico and in many regions of the world, also a large proportion of patients coming from middle-income countries, together also with high-income countries in many European participants as well. But this shows a better representativeness of the trial, and also we hope better generalizability of the results.
Absolutely, yeah, completely agree. And
yes,
what about the anticoagulants then?
Yes, so there's still differences, and that's also why we included the country income and the type of anticoagulation and cryptogenic CVT, age, sex, in the adjusted analysis, because there are differences. Of course, patients that come from middle-income countries more often are treated with vitamin K antagonists.
Right.
And indeed, some of the bleeding complications, indeed 3 of the vascular deaths that occurred in the trial were associated with VKA, were patients on VKA. And these patients were younger, had more severe presentation. These patients coming from middle-income countries were younger, had more severe presentation, more often more brain lesions, and more often were treated with VKAs, while patients from high-income countries were older, more often females, more often treated with DOACs and less parenchymal brain lesions, and also some signs of less severity in the presentation, like seizures and this type of presentation. So there are differences, indeed, and of course, in the final analysis, this will be all studied in more detail, and sub-analysis also on the risk factors and other possible differences across the groups will be more taken in account in more more detail.
Yeah. Fantastic work. It's a huge achievement to have such a large sample of patients with CVT. It's been an area where high quality data has been lacking for so long, and you're really helping all of your colleagues, I think, giving us the information we need to make rational decisions. So thank you so much again.
Thank you.
Annemien, over to you.
Yeah, beautiful work, and not to make it too simple, but maybe in this case less is more, less anticoagulation. And well, that also brings me to Professor Caso, Valeria. We were already discussing what's the highlight from so many nice trials, and then the word resources came up. So.
Yeah, thank you, Annemie. So I was very impressed by the nurse-led trial Optimist about the less intensive monitoring in patient with stroke undergoing thrombolysis and NIH less than 10. So I think what I was impressed, first of all, the quality of the trial, nurse-led trial. When I started, we had all academic trials. So now to see more and more nurse-led trials is so important, because we know that the quality of our work is done by the nurses. Every day they are together with the patients. And again, less is more. We saw that the less monitoring is superior, so it's not necessary. It's not inferior. It's not necessary to stay there. And I think a patient who feels less sick, not so intensively watched in an intensive care unit, feel that he or she can make it. And also, and you know, I work a lot with low and middle income countries. I know that resources is the first problem, because you can find a donor for an MRI, you can find a donor for a monitor, but you cannot find somebody who pays you a person, high qualified person. So if you can prioritize your resources based on what you have, so example, very severe stroke, M1 occlusion, okay, then you need all the resources, intensive monitoring. But if you have an NIH 10, and we know there's also a spontaneous improvement despite thrombolysis, and you know, a patient, when he or she feels less sick, it's already something that makes you feel better and improve your health situation.
And so would you now implement this in Italy?
Absolutely, because you know, we are considered a high income country, but we have a lot of problem with our public healthcare system, and what we see, the staff. Many of our wonderful nurses leave Italy because they are not so well paid like in other countries, and I lost a lot of good people. So I have really to prioritize. This is for me the first thing, because first point, I still want to give the best care to my patient, but I have to be realistic with the resources that I have.
Yes, and so this is one of the main takeaways I had from the session. Less is more. So less monitoring, and so when we come to the home visits and the rehabilitation, what did you think of that study?
Yeah, this was very interesting. I expected more, honestly. This is a very difficult domain about the perception, because you saw also that the ranking, the functional outcome was better, but the prompts were low. So we have to understand where's the gap. the perception of quality, how they felt, how they were follow up. Because, you know, and they say this very well, the European Action Plan wants to take care about life after stroke. Yeah. And here is a missing point. We do well in acute care, we have everything structured, but after, this was a tentative. It doesn't mean that we will not see better or more structured results, yeah. But I think it's very important.
Completely agree. I mean, a big takeaway from me from the last 3 trials in particular, firstly was how well they were all done.
Yes.
So the quality of those trials was excellent. The data they produced was excellent. Yeah. Also, coming back to your theme and your point about the nurse-led trial for nursing monitoring after IBTs, so we had, I think, 4 trials in that session. That's from 9
great, yeah.
that were led from non-medical leaders, which is wonderful to see. And then all of them addressing very pragmatic questions, very important questions for clinical practice that our patients and their families and the patient support groups tell us are really important to them. And perhaps the rehabilitation trials towards the end were maybe a little bit disappointing in terms of the outcome. I think some of the presenters mentioned that. But I think it does give us guidance, you know. Yeah. So very, very helpful. The Norwegian trial at the very end, last long. I think that tells us something. You know, maybe it is not the best way to invest all of our very heavily in resources, at least to that group of patients that were included in that particular trial. And one of the other themes that struck me from several of the trials that were presented towards the end were, for one reason or another, the patients that were included tend to be patients with milder stroke.
Yeah.
So maybe these are not the people perhaps who need that extra intensity of community care thereafter. And the other point that struck me was the stroke care intervention. Many of the interventions were focused on secondary prevention.
Yeah, and not so much.
But the follow-up was relatively short. Yeah. So maybe it was too short to see the harvest, the dividend and the benefit of those interventions. I don't know, you know, what your thoughts were on some of those points.
They showed us, I think, the feasibility, no? That was the most important point. So I think they start to show it can be done.
Correct.
We have, you know, we did it at the beginning also with acute stroke. We did so many trials that were failures.
Yes.
And then we learned to do the right trial. And probably now this was feasible. Now we have to find the right patient for as you said, maybe more severe patient, M1 occlusion, MRS 3.5, 4, something like this. Yeah. So these are the patients who certainly will benefit and feel less alone.
Yeah, and I would definitely say about these sessions, these trials were definitely not failures. They're learning us so much new lessons.
Absolutely.
Especially the methods were very sound.
Excellent.
Yes.
Completely
and
agree.
in clinical practice, it is difficult to do less sometimes.
Yeah. And guiding, as you say, Valeria, our resources are not infinite. So if we have high quality evidence guiding us to the best way to target our resources, that's very, very helpful. So I think all of the leads should be congratulated on
absolutely,
their work.
Always.
Yeah. And we had 2 acute trials from China, both giving us very interesting results. What did you think of those, Anna-Mie?
So I was thinking about where are we now with tenecteplase? Are we there yet? I don't know how the other European countries are thinking about it, but we're slowly implementing it in the Netherlands. I also hope to implement it soon in my new hospital in Rotterdam. I don't know, where are you in your countries?
We have the approval from IFA. We have an approval, but now is the next step. Now they have to go to the regions, then they have to go to the hospitals, and so on and so on. We are so ready. We want to do it. But it's slow. Bureaucracy, unfortunately, is slow.
And in Portugal?
Yes, in Portugal we also have a plan to have later this year, probably by the summer or so, an approval. And we are already also at the National Stroke Society and together with our colleagues that coordinate stroke units, planning the implementation and discussions together how to do it. So we look forward also to that specific change in daily care for our patients.
So that was my thought for this trial. We're really moving from the evidence to the implementation, which is a great step, I think. Another easy one.
One thing that I thought was curious and very interesting as well was the mismatch between the results of Bridge TNK and the previous trials and the meta-analysis, the IRIS meta-analysis from the previous trials that had used intravenous alteplase for bridging and failed to show such a clear signal. So I think that's a very, very interesting result and suggests that maybe we might have a role for TNK in bridging pre-EVT. So probably we need more data, I think, even though that was a very well conducted trial, a very large trial. So probably we need more trials, I would suspect, to alter practice globally.
And then, of course, there was I always struggle with the name tirofiban.
Yes.
Trial.
I think we all say it differently, don't we? Yes.
The truth is I haven't really wrapped my head around it. It is a promising result, absolutely.
We start using it together with stenting after thrombolysis. So I think it's a very positive result.
Yes. What did you think about it?
Well, yes, very interesting result. Seemed to be safe. Effect size remarkably similar to the Bridge TNK trial, so 20% improvement. An excellent functional outcome at 90 days, so that seems to be a real signal. So an exciting result, I think. Again, I'll be interested in seeing the detail in the paper. So a fantastic roundup there, and for our next discussion we are going to move on to the distal and MEVO trials.
So welcome back in the TV studio. So another important session today, and we have some great guests again. Here we have Marius from Bern. I'm not going to pronounce your last name, it's too difficult, sorry, and Wang. Very welcome. We're going to start talking about the MIVOs. We've already heard so much about it. But let's start with the update of the distal. Can you tell us something about it, your highlights, your takeaways? Where do we go from here?
Well, as you know, the trial was neutral. We presented that back in February. But I think one of the highlights of today's presentations was our sub-analysis. That's completely objective, obviously, right? I'm not biased towards that. No, but I think it's an important analysis that we did, watching after, also the imaging part of our patients. And what Kati from our team really nicely presented was that we were able to save more brain in the patients that received EVT. So even in this very specific group of patients that we analyzed or we included in the trial, as you know, patient selection was a topic among all trials, so I think this is something that we can discuss. But in this specific group, we still see a benefit for imaging from EVT. So I think this is an important message.
Yes, and one of the other messages, not from the distal trial, but I still wanted to bring it up to you as well, came from Michael Hill. He repeated it many times, that Back to the Future and that we need to be fast. Yes. Can you tell me something about timing?
Yeah. Tan, you want to elaborate on that? Shall I?
Yeah, please.
So Michael presented their sub-analysis of the ESCAPE-MIVO trial. And what they found is that in the really early time window, so under 3 hours, there is actually a benefit from EVT compared to BMT alone. So that is a reminder of time is brain, obviously. And that in their specific group, they can see a difference in MRS outcomes in the really early window. Mm-hmm. And I think this is an important message to everybody in the world, actually, not only in Europe, right? That we still are not where we should be regarding times and stroke treatment. If you see the distal trial, we had an imaging to groin time of 70 minutes. This is just too long. And it's the same in the ESCAPE-MIVO trial. They had a door to groin time of 90 minutes. This is just, more than in the LVO trials. And there are probably a lot of reasons for that, but still I think we have to work on, having systems that are faster. And one of my hobbies is, direct to angio, getting faster. We're launching now a trial on, call it Get Fast, actually, randomized trial on going directly to the angio. But I think, just one trial or two trials won't help. We have, as a community, have to start thinking about having a pathway that leads this patient directly to the best room, and I think it's going to be the angio.
Absolutely. I think you're so right there, Marius. I mean, one of the things that really struck me when I read those two papers was how similar the findings were for the two trials. Remarkably consistent evidence. That said, they weren't identical trials. Tan, what's your overall take on the two trials and related data? Maybe key differences?
Sure.
What do you think?
Between distal and ESCAPE-MIVO, some key differences in terms of starting with technique. The ESCAPE-MIVO was a stent retriever-based trial, so all stent retrievers, just the Medtronic stent retriever was the main technique to open up the arteries, whereas distal was more permissive. Any approved device could be included in the trial.
Right.
The time window of enrollment was a little bit different. ESCAPE-MIVO was up to 12 hours, and distal was
up to 24.
24 hours, so a little bit longer in distal, so we can see some differences there. Perfusion imaging was not mandatory in ESCAPE-MIVO. If you obtain it, then it, of course, would be recorded and then analyzed. And then after 6 hours, I believe it was mandatory in distal. So a few differences in patient selection.
Yeah.
The entry for severity of disease, pretty similar between the two trials, almost, if
Yeah.
not identical.
Yeah.
So I think that's the difference between these two trials and other trials of MIVO that are currently, ongoing or completed.
Yeah. Marius, distal allowed A1s and P1s while Escape Mevo didn't. Do you think that made any? Do you guys think that made any appreciable difference to the results of the trials?
No, I don't think so. It's a really small portion of our patient collective, and so I don't think that made any difference.
Yeah.
Yeah, they're pretty uncommon. I think the concern in Escape Mevo is that P1 is almost like an LVO because they often have motor symptoms with the brainstem going, being affected. So that's probably why they excluded it from Escape Mevo.
Yeah. And the other signal that really jumped out at me then was from Michael's presentation this morning. So, he really emphasized that, and it was highly statistically significant, that interaction by time, and, jumping back to what you were saying there about the need for speed and the need to get these patients straight into the cath lab. So is there room, therefore, for maybe another, distal 2, Escape Mevo 2, just a faster one, or possibly focusing on patients with a sweet spot of more severe stroke? There was a tendency towards benefit, a directional tendency towards benefit in patients with an NIH of 10 or more in distal, right? Mm-hmm. So I thought that was very interesting.
Do you have any information, maybe? Are you
I don't know. I don't know.
Over emails?
No, I mean, just wondering, though.
Yeah, that's. I think that's a logical step for the whole community. Like we had 2 trials or 3 with discount that were very broad in their inclusion criteria.
Right.
And so now we can make more analysis on the broad population and try to find a group of patients that will profit probably from this treatment. I can maybe disclose already that we have looked into time. It doesn't seem to be as relevant in the distal group, although we haven't finalized this evaluation. And one thing that seems to be highly relevant is imaging. So I think a future trial, if you want to call it distal 2, or I don't know how we're going to call it, is probably going to have an inclusion criteria based on imaging. We have seen that in patients that have an NIHS of over 6 and a Tmax 6 at baseline of over 60, there is a really significant treatment effect there. It's a small group. The trial was not powered for this answer, right? But still, we can take and extract some information and maybe plan the next trial based on such criteria.
Yes. What are your thoughts, Dan, on more selective targeting of these islands of patients within the overall distal and Mevo trials that may derive benefit?
Great question, Peter. So there's the Oriental Mevo trial, which is enrolling already patients with higher severity of NIHSS, so you have to be 6 or greater, whereas Escape Mevo and distal allowed as low as 3 with other disabling symptoms. They've completed enrollment in that trial, so it remains to be seen if they'll be positive or not. I don't know the results, but I think that'll be really interesting to see, does that change practice? And will that be enough to say, okay, we have a positive trial for these higher severity, so do we need to replicate distal or Escape Mevo for the higher severity if we have one potential trial coming out of China? So that's a big question that remains to be seen. There's the distals trial, which is looking at imaging endpoints for the reperfusion with devices compared to medical care. And so I think we need to learn a little bit more from that before probably you launch into your next distal 2 trial.
Yeah, and I think maybe until then, sorry.
No, you go ahead.
Maybe until then, that's something I'm going to talk about in the evening. Also, my idea right now is you have to have a really good risk-reward evaluation of those patients in your mind as a stroke physician. And I think maybe a comparison is a little bit like the stock market, right? Something that we can understand. Like if you have an LVO, that's like your blue chip, Okay. The risk is probably low and the reward can be really high. If you have a Mevo with a really low Tmax and a really low NIHSS, that's like, a penny stock where you can lose a lot and the reward is probably really low in the majority of the cases. So I think this is something that maybe we should not, go all the way, do 6 passes with every possible stent retriever.
Yeah, I mean, we already have some signals from the Hermes subgroup analysis by Bijoy Menon et al. It was published in JNIS, where patients with M2 occlusions with a median NIH stroke scale of 14 to 15, that subgroup showed positive benefit of thrombectomy. So they were much higher severity.
Yeah.
So the question is, do you really need this perfusion imaging to select patients if the patient's already coming at higher severity? And that's a big question in itself, where Hermes didn't, it didn't matter, these patients benefited because they were just so severe.
Yeah.
And then just having been a participant in the Escape MIVO, we looked at some of these patients who were medically managed. And of those that we enrolled who had lower severity, I was astonished at how well they did on medical management. Their MRS at 90 days, easily 0 to 1. So medical management shouldn't be underestimated. It's not easy to beat with thrombectomy. So I think we need to really consider the medical part is not easy to beat as opposed to someone who has LVO, where they're much more severe.
And then there's this one question left. What should we do about the collaterals?
Yeah.
It's a really interesting question. I mean, Michael showed some slides on his or their collateral analysis. They showed that people that had better collaterals tended to have a better therapeutic effect with EVT, and I think this is also an important point. Like, is it maybe that MIVOs have worse collaterals over time than an LV, or they behave differently, so the decay is faster, and that maybe brings us back to the time point, right? So even if the patient has good collaterals, maybe we have to be faster than a similar patient, LVO patient, that can have a longer decay of the tissue at risk to an infarct.
Yeah, and then this was also already mentioned, but then is there like a three-way interaction between all these factors?
Probably.
Yes.
Yeah, so I am going to bridge right over to segue over to Bridge TNK. Congratulations on that trial. Can you tell us a little bit about it and your interpretation, and how does it fit in with the previous data we have from the IRIS meta-analysis?
Yeah, thank you, Peter. So it was really a team effort from our colleagues in China, Zhang Mingqiu, Qingwu Yang, Wenji Zi, and Guangsong Yang. They all presented the trial on behalf of the team. So it was looking at tenecteplase prior to thrombectomy with large vessel occlusion compared to no tenecteplase prior to large vessel occlusion thrombectomy. And this was within the 4.5-hour window. So pretty similar to the patients that were enrolled in IRIS, except for the point that these patients had tenecteplase, whereas almost all patients in the IRIS were alteplase, except for direct safe, which had a few patients with tenecteplase. So it's a very different drug. The drug was from China, the TNK version in China. And essentially what it showed was that the patients who were in the intervention group, which was receiving the bridge, they did better than those who did not receive tenecteplase, and it was highly significant, supporting the idea that we should give TNK to these patients who are presenting direct to these EVT centers. And all patients in this trial were directly presenting to the EVT center. We didn't have patients who were at the outside hospital. And so, again, all patients who come to the outside hospital should still get the drug that they're eligible for.
Yep. So how do we interpret this with the previous, perhaps inconclusive alteplase trials? And what are your thoughts on why the signal is different?
Yeah, it's a terrific question. So the alteplase trials, they showed that there was superiority in the Kaismacher meta-analysis. They showed there was superiority of the drug prior to thrombectomy in the early time window, so 2.5 hours, whereas after there was almost like a ceiling effect, or they couldn't prove it that it was beneficial. Whereas in this trial, actually, the patients in the early group seem to do better with thrombectomy alone. So, they just go so fast that there's not much more to save after that early one. So it's kind of contradictory to itself.
Yeah.
So I think we still need to digest the data, but it depends on what you have available at your hospital. So if you have alteplase, then you get alteplase. If you have tenecteplase, you get tenecteplase. But if you have the choice between the two, then it would seem reasonable to go with tenecteplase because it's showing superiority, over the overall 4.5-hour time window.
Yeah.
So that's a major consideration.
Yeah.
And then in terms of your question of differences. Why is it positive? The tenecteplase seems to be more fibrin specific, has been shown to maybe have better recanalization results than alteplase. And so I think that's why we're maybe seeing a better signal
and
here.
quicker to give, you know,
Yeah.
when we're trying to get people into the lab, right, into the cath lab.
Yeah.
So it might be as simple as that, perhaps, and back to speed again. So I think the main take-home is do not withhold the thrombolytics in patients with LVO on the way to EVT.
And maybe
right?
they even have a use for really distal occlusions, right? So this is something, you know, as the next bridge now.
Bridge 2.
Bridge number 2.
Bridge 2.
We can easier give it also intraarterially.
Right.
For us, it's a use that we do for Techno, for example, for the Techno trial.
Yeah.
And we also think that maybe there is a use for those SIM4 occlusions that, of course, we can, or the star interventionalists can navigate there, right?
Yeah.
But you don't have the star interventionalists every night and every weekend in the hospital. So maybe, you know, when you have a young fellow that's not so experienced, it's better to give some TNK intraarterially.
Yeah.
So this is something we have to test in future trials.
Yeah, fantastic steps forward today. Well, with that, we'll wrap up our midday highlight session of ESO TV. Once again, I'd like to thank my co-host, Alamin Algra, Tan Nguyen, Marius Sikogius. Enjoy the rest of the conference.
afternoon, everyone. My name is Silke Walter. I'm a German neurologist, and it is my greatest pleasure to be here today with my co-moderator, Sarah Gorey from Dublin University, with Professor Zhao Jing from Fudan University. She's a lead investigator of the 120 Stroke Awareness Program in China. That's an important and huge program, and we will hear a little more about this program in some minutes. And with Professor Melinda Rhodeson, she is from the Arctic University in Norway, and she's the SAPI, the Stroke Action Plan Europe, Chief Operation Officer. And Melinda has a lot of experience in stroke awareness and how we can manage to have our patients arriving at hospital much earlier than at the moment. And we are straight away in the center of our today's topic, which is pre-hospital delay.
Yes,
Sarah.
Pre-hospital delay is any delay that causes the patient to be delayed coming to hospital. And there's so many factors that can contribute to this. And about 50% of our patients don't arrive in time. I know that in Ireland, only 10% of patients get thrombolysis, and a big driver of that is pre-hospital delay. But I'd be really interested to hear, Professor Xiao, about the experience you have in China of educating the emergency services to try and improve pre-hospital delay, and what your experience has been like in China.
Yeah, we have worked a lot of years to promote the emergency staff and community doctor education, because you know the stroke center have progressed in China for many years, and then the thrombolysis was used in every county level hospital. But the thrombolysis rate is so low in China, about only 5%. Yeah. And the main reason is the severe pre-hospital.
I think education of emergency staff, as you said, is really, really important. Paramedic education, emergency doctor education.
Yeah.
How did you approach that? What educational program did you start?
Yeah, because about 10 years ago, the emergency staff didn't know the thrombolysis method and the thrombolysis window time. So when they received a stroke, they didn't know it is as fast as go to the hospital. So we began to educate the emergency staff and the community doctor. And first, we always think they are the important people to be educated. And first, then they will promote the education to the public. So we made many lectures to them, and it made a great progress and the education program.
I mean, this is certainly very clever. You have to start at some point, and of course you're right, if those who deliver the care, if they don't know what therapeutic options there are, we wouldn't reach any aim. And I think we have developed stroke medicine quite a bit in the last decade, but now it's really about how to get the patients to hospital very fast.
Exactly. If the patient doesn't arrive at the hospital for us to give the acute treatments, it's a big problem. What kind of improvements did you see after you started engaging with the emergency services to better educate them about stroke awareness?
Emergency staff and the community doctors are very huge in China, and we have the organization by our government. So we often built a team to educate them, and after the education, their stroke awareness enhanced remarkably, and through our Stroke 120 program, our emergency number, call emergency number rate from about 5% to 33%.
Wow, so an improvement from 5% to 33% after bringing in the Stroke 120 program.
Yeah.
Fantastic.
That's fantastic news. And the pre-hospital delay from 15 hours reduced to 6 hours.
Brilliant.
Okay.
So before this program, it took on average 15 hours for someone to reach the hospital, but after the education, it was down to 6 hours, which is really good news.
Yeah.
Fantastic. And
the point is, time is brain, as we all know.
Yeah.
And every 1 hour delay results in 11 months of healthy life lost. Actually, even 15 minutes delay worsen outcomes. So this is very important, the work you have done.
And especially, 15 minutes in the pre-hospital setting is literally nothing.
Yes.
This is just, time runs so fast, and you lose 15 minutes. Feels like a second, and that is certainly a big challenge. Having all the EMS teams, paramedics educated is a very crucial point, and I think we have to work on that much more, because medicine has developed a lot, stroke medicine has developed a lot, and of course not everyone. They are generalists, usually paramedics and emergency doctors. So we need to tell them, listen, now we can really treat these patients, but we need your help, kind of.
Stroke care has actually revolutionized
correct, exactly,
the
it's
last
a revolution.
30 decades, and it is the most cost-effective treatment.
That's an important point. That's an important.
We must work on multiple levels, not only to the general public, to the paramedics and the GPs, the family doctors, the ones that are closest to the patients out in the community. And this is so important.
Yeah. It's quite a complex pre-hospital cascade, and it also, of course, involves the dispatch center. So usually what we know is that if people call the ambulance service, they arrive at hospital much faster, they get a faster in-hospital treatment, that is quite clear. But unluckily, we face the problem that dispatch accuracy is not ideal. So it ranges between 30 to 50%, which is definitely clearly not enough. So we do miss stroke patients, they get dispatched as non-stroke patients, and if we're unlucky, they don't get identified at the emergency site. But also, stroke patients or patients get dispatched as suspected strokes who aren't strokes at the end, and they then, we all know these systems are stretched, and they then add a little more to this already quite overcrowded and difficult to manage system. So, does any one of you have any experience with dispatch accuracy or you've analyzed that in your program, dispatch accuracy, and you've worked on that, Professor Chow? Do you want to share with us some of your experience?
So I think the public stroke awareness should be promote covered all ages, for elders, for adults, or even the students. So when we promote Stroke 120 in China in 2016, and why we promote this project, because fast doesn't work well in China. Most of Chinese don't know English, and they didn't know the meaning of the fast. And even though when fast was translated into Chinese, it loses its meaning, the speed. So the people don't understand it. So we link stroke to 120. 120 is the unique emergency number in China, and everyone, almost everyone know it. So we transfer the 3 number into 3 identified steps. 1, look for uneven face, and 2, to examine the weak arm, and 0 to listen to the slurred speech, and we link stroke to emergency number, so people recognize the symptoms and evoke them to take action immediately. So
Yes,
it is easy
this
to.
is very important.
Yeah.
Drive in meaningful campaigns that provide a context to the nationalities, and this translational work. It's so important.
And we hope the experience of stroke 120, stroke plus emergency number, will be benefit for the non-English speaking country.
And that's quite a very important point you raise. What we have to keep in mind, systems are so different, and there are different characters, luckily, because otherwise the world would be really boring. But we have to keep in mind that all these pathways we develop need to be adjusted to the local setting. Because there are so many different regions, there are so many different countries, and it must fit to the local situation, otherwise we will not succeed.
And I think our challenge for the future with stroke will be delivering care in lower and middle income countries. So this type of work that can translate the FAST score, the FAST sign, cannot work in every context. So
and
to
link that to immediate action, and in an expert opinion summary statement from 2024, led by the World Organization Task Force for Pre-Hospital Care, recommended that changing stroke awareness to stroke action awareness is so important for it.
That's right.
Yeah.
That's right.
The action word is
exactly.
important, that
action,
you recognize it and then you act, that it's not enough to just recognize.
And I mean, patients do know that for a heart attack, but it's so painful, they would always call. And for stroke, we really have to transfer the information that symptoms means action now and not later.
So we promote from stroke awareness to stroke action awareness. If you recognize the symptom, but you don't take action, and the pre-hospital is also delayed.
Correct. That's very correct. And we have that challenge that it's very different in every region, and you're completely right, Sarah. Low and low middle income countries, they've got a completely different system. But not only that, we also have higher income countries that have rural and remoter areas, and it's very difficult to look after these patients because the next healthcare facility might be quite far away. And I think, Melinda, you've got some experience coming from the Arctic University.
Yes,
you have some experience.
That is true, and it is quite a lot of innovation that comes from Norway regarding this, and there is e-stroke app, for example, that the Paramount that Esoc and Let Sunset that, and even our local university has an innovative project regarding pre-hospital care using an innovative kind of telemedicine solution, and it has gained quite traction. There were visitors from Mayo Clinic in December visiting
the area. The area to see how it goes.
Yeah.
And I mean, we must be very innovative and we must be creative, otherwise we will not find any solution. How do you do that in rural Chinese areas? It's difficult.
Yeah, how to improve Chinese public awareness.
And in rural areas where there are not many hospitals, how do you get these patients?
How to is so I just said all ages of people should be educated, because the stroke may occur at any place, or at home, or in the public, or in any other area. So we produced a series of material and aims to different ages, for elders, for adults, for students, and for elders. We first educate community doctor and emergency staff, and they began to promote the stroke 120 in the community. And so they are the main force to go deep into the community. And
kind of a domino effect.
Yeah. I mean, and second, aim to adapt, because all of us go out to work. So we use the platform, the social media, the online. So we produce the video, especially short video. Short video very popular in China. So we shoot 1 minute stroke 120 video, and to play online all of the China, and many our colleagues translated our video into 50 dialect.
All right. Okay. Yeah.
50 dialect, and so many people like their dialect. So the online the spirit is very large.
It's so important to reach as many people as possible, and these resources sound very useful to do that.
Yeah.
So how do we reach people? How do we make sure that if a person is experiencing a stroke, or their loved one at home experiences a stroke, that they know that they need to act, and that they don't delay calling for help? How can we work on that?
We must work with multiple campaigns in multiple levels, in multiple planes, relentlessly.
And that's a crucial point. If I may just, for the audience, add that we know that public awareness campaigns, they do help, but we also know that all these campaigns, after a period of roughly 6 months, the awareness goes down again. And this is quite a relentless job to do and to constantly work on.
Yeah.
And you've got a lot of experience.
Yes. I'm coming straight from Geneva, actually, to Helsinki, and the first in-person event of the Global Stroke Action Coalition. And it is first ever global advocacy movement to reducing the burden of stroke for everyone, everywhere. And it is crucial for someone every 2 seconds is having a stroke.
Yeah, that's an important information. It happens all the time.
Yeah.
And you are right. It needs joint efforts and joint forces to tackle that problem. That patients, if we manage everything perfectly in hospital and also in the EMS, the emergency medical system, we still have to tackle that problem that patients don't call early enough. Yeah. And you've done a great job there.
Yeah. And I think it is so important. This Global Stroke Action Coalition was launched in April, and it is driving momentum and change up until the UN high-level meeting on NCDs in September this year. So look out for various activities regarding that. And it is of course ESO endorsed, and it is multiple stakeholders all over the world, and it is driven by the World Stroke Organization.
And it is aimed at raising awareness in the public, just to emphasize that again.
Yes.
So what we can all do is probably share that information that there is a stroke coalition, so that everyone in every corner of all countries knows about that at the end, hopefully, of that year.
Yeah.
Similar to what you've done with your 120 project, or what you are still doing.
Yeah.
I guess you are still going on educating the public.
Yeah.
It's relentless, isn't it?
Yeah, yeah. And we produced a lot of many kinds of material, like the video, like the book, like the comic, and the game for students, and the minor film, and I introduced one of our minor film, the Wake Up, Stroke 120, Wake Up. The Wake Up won the International Minor Film Award in New York, and the president of this minor film, president of the game,
society.
the robot, Mr. Robot, was deeped by this movie.
Yeah, that's quite a great idea to translate it into modern.
Artist method, because his brother died from stroke.
Right. Yeah, that's it. Personal motivation
And
is got there.
Dramatic is a year later, he occurred.
Oh dear.
Stroke, and he reminded the stroke 120 in our film. So he called 911 immediately and go to the hospital, ask for the help, and get thrombolysis and recovered immediately and come back to his work. And also later we make another microfilm about his experience. The name is "This Movement Saved My Life."
That's fantastic work. That's really fantastic.
So important to incorporate lived experience, and that is a crucial point. And I think we have to have a lot more of that.
What would be your most important message you want to share with all, coming just from the coalition meeting in Geneva?
Yeah, I believe we have to join forces. We have to work together to put stroke in the forefront of all entities. As I said earlier, it is the most cost-effective treatment, and it is quite mind-boggling that it has not been
that has been emphasized
earlier. I think we have a big job to do, and we have to join forces, not only academia, but clinicians, the lived experience community, the stroke support organization, the carers, and the general public must know. And most importantly, we must involve the policymakers. They are the ones that can drive change.
The word must spread.
Yes.
And I think you brought a little video for us,
Yes.
which we would like to share with the audience today. And otherwise we would actually say thank you for listening to this ESO TV session.
And thank you to our guests who are two real leaders in improving pre-hospital delay worldwide. So thank you for joining us and sharing your experiences.
Thank you.
Thank
bye-bye.
you.
Stroke is preventable, treatable, and recoverable.
Recent breakthroughs have revolutionized the prevention and treatment and bring the potential to cut the burden of stroke in half.
Effective stroke treatment and rehabilitation improves patient outcomes and reduces disability and dependency.
Alleviating the burden on families, caregivers, and communities.
Every minute a stroke is untreated,
1.9 million brain cells die.
every minute counts.
We need
Stroke action
now.
welcome to the last session of today at Esoc TV, where we have the lead investigators from Optimist Main trial. We have Debbie Sanders, advanced research nurse from St. Luke's Hospital, Professor Victor Urrutia from Johns Hopkins Hospital, also in the US, and we have Professor Craig Anderson from the George Institute in Australia. It's a pleasure to have you here.
Thank you for having us.
First of all, congratulations to this major achievement. You have enrolled nearly 5,000 patients across 114 hospitals in 8 countries since 2021. That's a huge achievement. Congratulations.
Thank you.
Thank you.
So for those who weren't able to attend your presentation this morning, could you briefly summarize what you were trying to investigate with the Optimist Main?
So we were trying to demonstrate whether a lower intensity monitoring protocol, and I'm talking about the clinical monitoring that the nurses do at the bedside after a patient gets treated with IV thrombolysis, was not inferior in terms of functional outcomes and safety outcomes to the standard monitoring protocol, which has been in place since the original NINS trial in 1996. So for that, we did a step wedge, a cluster randomized trial, and in which all the centers started with the standard monitoring protocol and switch at different rates to the low intensity monitoring.
And
I don't know if my...
Yeah, what were the main findings of this Optimist Main trial?
You want to answer that, Craig? And I'll do the nursing portion more.
Well, look, I mean, across all of the clinical outcomes, our traditional functional recovery measure and all the other measures of quality of life, sleep, and all of the safety measures were comparable across both of the treatment arms. But most importantly, the safety measures that we worry most about, intracerebral hemorrhage, were very low in both groups, 0.2%, so 2 in 1,000. So this monitoring protocol that we've been using for 30 years, it's primarily to detect complications of thrombolysis. And in this patient group that we included, mild to moderate clinical severity, an NIH stroke scale score of less than 10, the rate of intracerebral hemorrhage is very, very low. So it's a very safe, stable group, and we've shown that you can relax the monitoring protocol without jeopardizing the patient's recovery or causing any harms.
I think one of the additions would be that we have for years kept these patients in the ICU, and that's an intensive resource. Many times the nurses taking care of 2 patients, and hospitals are starting to move patients out of the ICU, and I think this shows that that would be safe. There's been some reluctance with administrators, but this helps to show that it would be safe to move these patients and could be a cost savings.
And if the nurses don't have to monitor so often, or taking up the ICU spaces for the patients, what can these nurses do instead? Are there other important tasks that we could shift the work over to?
Well, that has always been my compassion and what is good for the nurses. And nurses do a great job checkboxing, and they could get all those vitals done, but then they're unable sometimes to sit down with the patient, provide the psychosocial needs, provide just the compassion. These patients have had an acute stroke that has rocked their world. And being able to educate them, be able to provide comfort needs, just sitting down and discussing with them what's going on, what the team is doing, I think will help alleviate and give nurses empowered more to take care of those patients.
If I might add as well, specific tasks like mobility programs where the nurses are in charge of making sure that the patient is moving recovery and rehabilitation tasks that the therapist may delegate to the nurses because they can be there for a longer time. Education of the patient and the family, in addition to all the important tasks that Debbie mentioned.
Excellent. How did patients, nurses, and clinicians that were involved in this trial, how did they perceive this intervention?
Yeah, we did an implementation assessment, which is also published today as a poster here in Esoc. And what it found is that the implementation of the protocol was easy to conduct. The nurses, the physicians were all favorably inclined to the new protocol. They felt that it was useful and safe. So we think that it has had very good acceptance in the trial.
There could be a little reluctance to change initially. At my center there was. I can't check, I'm not checking them enough.
No.
I'm not. So just getting comfortable with that and seeing that the patients do well. I think another really important about this trial is United Kingdom was very successful in utilizing nurses as PIs. And it really engaged the nurses. Yes. And if we're going to have more nursing research, we need them to be engaged. And they saw it as a practice change that was beneficial to them and the patients.
It's very important. So one last question. If nurses and clinicians are interested in implementing this intervention, what advice could you give them?
Well, they can always reach out to us, and we will definitely be happy to help them. We also have we've published the results of the clinical trial, the results of the implementation assessment, and there are other studies that we have published, other papers that we have published before in terms of how to implement it. But again, I think that we will all be happy to help. If I might say one more thing, I think that and this is something that goes back to when we met originally, during the pandemic, the American Heart Association published an emergency scientific advisory where they mentioned the Optimist pilot trial and proposed that as a possible way to save on resources during the pandemic, ICU resources. Yes. And that was a small trial that we did at Hopkins, only 35 patients. And what we sought to do was to conduct the definitive trial for this, and I think we have. Yes. I think we have a large multinational trial that showed that there is really no harm and no decrease in benefit to the patients of instituting this protocol.
They need to identify a nurse champion. They need to identify a physician that's going to champion with them, change their order sets so that they have the knowledge of what patients would be eligible for that, and reach out to us, I think. I think it's...
Excellent. Thank you so much for coming here. And that's all for this interview. Thank you.
Thank you.
Good evening and welcome to the last Esoc TV session of today. We are joined today by the lead investigator of the Bridge TNK trial, Dr. Yuan, and by Dr. Tang. Dr. Yuan, could you, for the viewers that may have missed your presentation earlier today, could you quickly summarize the research question you were trying to answer in your trial and how you went about that?
Okay. Our Bridge TNK trial aimed to determine whether intravenous tenecteplase before thrombectomy improved functional outcomes compared to thrombectomy alone in patients with acute ischemic stroke due to native cell occlusion within 4.5 hours of onset. This was a multi-center, open-label, randomized trial across 39 Chinese centers. We enrolled 550 patients, assessing 90-day functional independence as the primary outcome. Key exclusion criteria were native cell occlusion confirmed by imaging, eligibility for thrombolysis, and absence of prior thrombolysis.
And could you maybe comment on the main findings of your study?
Okay. The tenecteplase group achieved 52.5% functional independence versus 44.1% in the thrombectomy alone group. P equal 0.02. Tenecteplase also increased pre-thrombectomy reperfusion 6% versus 1.1% and shortened puncture to reperfusion time 55 versus 62 minutes. Safety profiles were comparable. Symptomatic intracranial hemorrhage occurred in 8.5% versus 6.7%. P equals 0.33, and the mortality was 22.3% versus 19.9%. P equals 0.39.
So not only an improvement on functional outcome at 3 months, also more early recanalization, right? Which is in line with the Extend IA TNK trial, which was published a number of years ago. Could you perhaps comment on why this trial is superior as opposed to the earlier bridging thrombolysis trials, which didn't show superiority?
Okay, so I think the most different between Bridge TNK and the previous trials is in previous trials mostly the thrombolysis used alteplase, but Bridge TNK used TNK. And for TNK, there's a very specific pharmacological characteristic such as longer half-life time and higher fibrin specificity, and also more resistant to endogenous inhibitors, which enables a faster and more robust lysis effect. And this experience a higher rate of early reperfusion. We could see that in the intervention group, this 6%, while in the control group is only 1%. And also it reduced the thrombectomy complexity. We could see that in the intervention group, the angioplasty all standing as far as go to 90%, but in the control group is 27%. So all this shortened the procedure time, and we could see that in the intervention group, the procedure time is 55 minutes, but in a control group is 64 minutes. So these all factors improve the outcomes. And we could also see that the tenecteplase do not increase the safety issues such as hemorrhage or symptomatic hemorrhage.
Mm-hmm.
Yes.
Mm-hmm. Okay, your study seems to be very timely since the world is slowly switching to tenecteplase rather than alteplase for thrombolysis. I had one last question. Could you maybe comment on the time interval between thrombolysis and initiation of thrombectomy, since this was a study of non-transfer patients, right? All patients were directly admitted to comprehensive stroke centers, is that correct?
Mostly, yes, because we could see that the thrombolysis to puncture time is about, the median time is 60 minutes, so it's actually very short time. The first reason is that most of these sites are comprehensive sites, and also we could see that the efficient workflow, the workflows is efficient, and also we could see that it's highly trained in all sites. And the one reason is also possible contribute to this is that for tinnitus, it's like just one bonus injection, and this also contribute to the very short time.
Yeah,
yes.
Exactly.
Yes.
All right. So, well, finally, I want to congratulate you on this positive study. The study is live on the website of New England, so I would invite all of our viewers to go and check it out. Thank you for being here today, Dr. Yuan and Dr. Stein.
Thank you.